Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to this episode of the Tate Chronicles. Today's episode is sponsored by Hewlett-Packard, the leader in the world's most secure and manageable PCs. Learn more about HP's Healthcare Edition products at hp.com/go/healthcare/US. I'm very pleased today. My guest is Matthew Fisher. I've known for quite a number of years. He's a partner with the law firm of Merck O'Connell and is the chair of their health law group. His health law practice includes advising clients with regulatory, fraud, abuse, and compliance-related issues. Matt is well known in the healthcare domain as the person to go to for advice on the intersection of healthcare and law. Matt, thanks for joining us today on the Tate Chronicles.
Well, Jim, it's a pleasure to be here, and happy to be chatting with you again. As you said, it's been a number of years that we've known each other now, so I'm always happy to be able to catch up.
Yeah, thank you. Well, let's cut right to it because there are a number of things that are changing rapidly, mostly related to the COVID-19 pandemic. There are a number of areas of discussion I'd like to cover with you, Matt. But let's first talk a little bit about the CMS waivers, telehealth and fraud and abuse and paperwork, those kind of things. Could you give us an overview on those, please?
Sure. Kind of as you said, it's kind of unprecedented times right now, and with the declaration of the pandemic and the corresponding declaration of emergency, the government has taken a number of steps to make it easier to access healthcare services. Kind of as you said, the opening of telehealth services and waiver of other paperwork requirements are arguably some of the biggest changes. The telehealth clearly is definitely driven towards trying to open up access by allowing patients to interact with their physicians and other clinicians without having to go into the office, since a lot of people are under stay-at-home orders or other social distancing requirements. And then, in terms of paperwork reduction, it's some of the more recent waivers are talking about getting advance payments and not having to go through as many of the administrative hurdles and burdens that are so often cited as why healthcare ends up being a bit of a morass.
Let's jump into the details of those just a little bit. I'm going to tell you some things I've heard, and you can tell me if I'm off base or if they're accurate or just what the story is, Matt. In terms of changes for telehealth in terms of reimbursement, it seems like the recent declaration of emergency based on the COVID-19 has allowed Medicare providers to bill and be reimbursed for the same amount, whether they're patient comes to the office or if it's a telehealth visit. Is that correct?
Yes, that is correct. As you said, the waiver and expansion of ability to access telehealth, it wouldn't have been enough to just say, yeah, you can do the telehealth visits, but as you said, having the reimbursement be equal was, in my view, really fundamental and necessary when encouraging the shift to that. Because if you think about it, with patients not wanting to go out and clinicians telling patients not to go out unless it's absolutely necessary, if you told people, yeah, you can do a telehealth visit, but you're going to be reimbursed at a reduced value as opposed to an in-office visit, you'd have kind of countervailing pressures. And given the fact, as I said, that so many people don't want to go out and you've seen a drastic reduction in the number of visits, being able to, hopefully mitigate some of the financial harm by having co-equal reimbursement, again, in my view, is really necessary.
There's another part of that. I know that is for Medicare, and I believe as of right now, that rule or standards for reimbursement for Medicare is in effect for the duration of the emergency, whatever that is, length of time that is. It's kind of open-ended. Do you think there's a possibility that once this all passes by, there'll still be that reimbursement? Have we made that giant necessity the mother of invention where it will continue to have those equal reimbursements? Is that a possibility?
Yeah, no, I think that's a great question, and certainly one that seems to be getting debated a lot right now. as you said, the necessity here has clearly driven the change, but I've kind of talked about this with others as well. It's you honed in on really the key part right now, which is all these waivers and changes are only possible because there is that emergency declaration. So once the emergency ends and that declaration is no longer in effect, then all these waivers disappear with a flip of a switch and it's back to how it was. Hopefully at that point, and maybe leading up to it, if we're able to have somewhat of a wind down, and it's not just an immediate change from a state of emergency to normal operation. The goal would hopefully be, you get to see all the benefit from having care delivered through the means of telehealth, and recognizing that it really does allow for a good and natural extension of care, that you have discussion around that, and maybe you can have legislation that recognizes that and allows for some of these changes to be made permanent. Because I believe you're going to need legislative change in order to get the full scope of these modifications in place. Because if you look back over the past couple of years with Medicare adding a little bit of coverage for telehealth, and you've got some of it that was driven by legislative changes that have occurred, which then gets fed into the different fee schedules that Medicare comes out with on an annual basis through the regulatory process. So I think if you're looking to really embed full and equal reimbursement for telehealth, you're going to have to be looking for legislative change, since maybe going in that direction without the statutory authority might draw challenges or argue for an overstepping of the regulatory authority. So that's kind of the procedural background, but at least from my perspective and opinion, I do think that this period of time is going to get us past, or get the industry past what has been arguably a bit of a hype stage for however many years now, because I don't think I can count how many times each year has been designated as the year of telemedicine or telehealth. But now, the technology and the digital health platforms have the opportunity to prove out the benefit that has been repeatedly promised. And I really do think that and expect that to occur, in which case you've got a really solid argument for making the changes permanent. But as I said, it is going to require some sort of action, because otherwise, the ability to have what has, the waivers and the modifications that have been put into place, that ability is solely driven by the declaration of the emergency, which opened up the ability to have emergency powers and to implement these waivers.
One thing about this telehealth and related technologies, we've had them for some time. Nothing has to be invented or discovered. They were there ready to pull off the shelf as soon as there was this compelling need based on issues around COVID-19. Now, I believe not only the equalization of reimbursement for visits through Medicare, and I think state by state on the Medicaid side, states have the authority to do the same thing. Some may be, vary how they do that. But telehealth, from my understanding, can all be used for some of the certification and recertification of home health, hospice patients, and I believe also for renal physicians and their face-to-face with their renal patients. So I guess that's part of that, reducing the paperwork burden. A lot of those things do not have to be done face-to-face.
Yes, no, that's correct. And I think that all stems out of I'm not even sure what round of waivers or changes it amounts to, but I think that all stems out of an announcement on March 30th or thereabouts, where, as you said, they extended the waivers and the ability to really tap into to telehealth to a lot more circumstances other than just kind of the physician office visits. On top of some of the ones you listed, I think there's also been expansions for emergency medical transport, where I believe ambulance companies are also now able to provide some level of telehealth. And it's also not just applicable to physicians, but you're allowed to have non-physician clinicians also involved in the delivery of telehealth services. So it's really become quite expansive, and again, it's all geared towards being able to provide needed services without having to do it in person. Kind of the caveat on top of all of this is if a service is not capable of being provided by means of telehealth because there needs to be some sort of a physical examination, then you still have to go through with that physical examination and figure out a way to see the patient in person, because it's not just, there is the recognition that, there's kind of, I like to think of it as a continuum of care. There are certain things that, yes, you can clearly do without having to be in the same room as the patient. But, if you start getting into an area where you need to have some sort of physical interaction, then these waivers are not dispensing with that. You still need to get the patient in. Obviously, you want to think about how that can be done as safely as possible. It's really not a cure-all, nor do I think it ever could be. And I think this will help tease out those distinctions of, this is where telehealth is appropriate and this is where it isn't. Kind of a good example in that regard is, hearing about OBGYNs. If you're talking about prenatal care, there are just certain things that they can't do remotely, and they have to, figure out how to allow expectant mothers to come in and be able to safely receive treatment or receive services. So it really is a bit of feeling out, but I think those distinctions are being figured out pretty quickly.
Matt, one thing you mentioned was that through telehealth, under the emergency rules or regulations or declarations, non-clinical individuals can they bill under a provider's NPI? What's that about? Non-clinical.
Yeah. So, like a nurse practitioner, can bill Medicare directly. So I think that, again, an NP will be able to provide telehealth services, as well as a physician assistant, and and even depending on some of it, other types of physician extenders or support can help do the advanced work just as if you were in the office. There's, I haven't necessarily dove into the specific details, but there's also the ability to do incident to services, which is a way to have an MP or a PA bill under the physician's MPI, and then because you're billing under the physician's MPI, you're getting the physician level reimbursement. But if you're going to be doing that, you need to be cognizant of all the elements of being able to bill incident to.
Absolutely.
Since it's it's not just a free-for-all, nor would I think anyone ever expect that anything under Medicare or any of the federal payer systems would allow for things to be done without some level of process. Because even though we've got the emergency and you want to make sure there's access to care, and we can get, well, I know we'll get into it a little bit more in terms of some of the other waivers, specifically on the fraud and abuse side, there are still some fundamental requirements, that the government isn't going to want to see, outright disregard for or subversion of some of those requirements.
Certainly. Let me mention to our audience, if you're just tuning in, you're listening to Jim Tate and the Tate Chronicles. Today's episode is sponsored by HP, the leader in the world's most secure and manageable PCs. You can learn more about HP's Healthcare Edition products at hp.com/go/healthcare/US. And be sure to follow the company with the Twitter handle of @HP. Matt, you kind of touched on a little bit some of the OCR, or Office of Civil Rights, waivers and enforcement discretion. This is kind of the area starting getting into HIPAA. What's going on there?
Yeah, with the expansion of the use of telehealth, you had the Office for Civil Rights, which is one of the co-agencies under HHS, along with CMS, give some guidance, and it's not really a waiver for what they've done so much as they say they're exercising their discretion not to pursue or impose any enforcement. And what that has done is said that clinicians can utilize non-public facing services that aren't necessarily HIPAA compliant for the delivery of telehealth services. In the announcement of the discretion, things like FaceTime, Facebook Messenger, and Zoom were actually specifically referenced as potential options. Interestingly, if you actually kept reading that announcement all the way to the bottom, after discussing the fact that you could use these non-public facing general platforms, it still did give some examples of HIPAA compliant services that can be utilized. Some that are certainly gaining more prevalence now because of the emergency, or that have been around for a while. And kind of frankly, I've talked with clients and I've talked with others where, I think it would be best to try and go with one of those services that is HIPAA compliant now. They're probably some of them are just as easy to set up and get up and using as the services that you might use in your regular life. And then it, kind of touching back on what we've been discussing earlier about, what's the telehealth landscape going to look like after the emergency, you'll already be ready to use those services. You wouldn't have to all of a sudden change what might have become an ingrained workflow of using something like FaceTime. If you're using a compliant service, then you just keep on using it and you don't have to worry about it. Another aspect to it is if you're using a non-compliant service, even though OCR isn't going to be exercising enforcement powers, it still does have an impact on privacy. I think using the example of Zoom, Zoom's been getting hammered in the press a lot because now that its use has exploded. I think I saw numbers where, at the end of 2019, I think they were having about 10 million meetings a day, or 10 million users per day. I think I saw a report for the last week of March that was exceeding 200 million per day. Their policies were not necessarily very protective of the information that could be recorded through its system. If you're talking about healthcare and you have a free-for-all with the data, where is that going to go? And, even though everyone is scrambling and understandably just trying to figure out how do we continue delivering care to patients, I still think there is room there to think about ensuring the privacy and security of data, especially because, as I said, services that do comply with HIPAA can be just as easy to set up as something like a FaceTime or a Zoom. And then the other aspect to it is, if you're talking, because I've seen some practices tell the physicians, oh, just use FaceTime. Not every physician wants to give out their personal cell phone or email to enable that connection with the patient over FaceTime. So there might be just some practical pushback from the people who are being asked to actually deliver care through some of these platforms.
There's certainly a requirement that if there is a billable encounter, there's got to be some kind of documentation. And even if you're using a very lightweight telehealth application, maybe at the same time, documentation is done in a provider's EHR or something like that. But you'd want some type of audit log that, with at least the metadata showing that the encounter took place, who it took place with, and the length of time of that encounter.
Those are very good points.
Just as a best practice. Let's go and talk a little bit about state changes. I know there's a lot of things. First one that kind of comes to mind is the relaxing of licensure requirements. Somebody goes from one state to another to try and help out. We've been seeing out in New York. They're saying, come help us. So what's the story about relaxing licensure requirements?
I think as most people know, licensure of physicians and actually really any type of professional clinician, or really, I guess, really all professions, is on a state level basis. That's why every state has its own board of licensure for each of those particular professional licenses. But, as you referenced, recognizing the fact that, telehealth might be on the rise, or maybe even just hopefully that if hopefully some states aren't impacted as greatly, that some of the clinicians might be able to go from those less impacted states to the more impacted ones. Some states have either just said, as long as you're licensed in a state, you're allowed to practice here, or have made the licensure process basically happen within a day. But all that goes to recognizing the need that you want to have people have the ability to provide services to patients. And, it arguably goes towards some of the arguments and issues that have been raised about why can't there be national licensure compacts, or why can't there just be a national level license. But, at the moment, it really is a state by state determination. And I don't know if I have a specific count of all the states that have taken action, but it is in every state at this point. And each state has done it a little bit differently. And then also, it helps to provide some clarity around some of the announcements that have come from the federal government, where a couple weeks ago, there was some suggestion that the federal government was waiving licensure requirements. But if you start going into some of the more recent guidance around how the waivers, in particular the telehealth waivers, operate, there is recognition that each state controls licensure in that state. If you're looking for a waiver, you need to find it on that state level.
One thing that kind of complicates that a little bit is in these areas that are really COVID-19 hotspots, it literally is a super emergency, and you see government officials pleading for people who maybe have retired, providers or nurses, or no longer have an active licensure to come on the front lines and help. So I know kind of a state by state or maybe a county by county thing, they're trying to work out all those kind of things.
Yeah, and on top of trying to get as many people in there as they can to provide services, there's also been, some states taking steps to allow medical school students to graduate early, or nursing school students to graduate early and start to begin providing practice. I'm here in Massachusetts, and UMass, they had their fourth-year medical students graduate either last week or earlier this week, and so they can start being able to step in and help out to the extent that they're able to. But then kind of all related to that, not every state, and I think there's only been a couple that have taken the step so far, but also to provide liability protection, because while we were going through this pandemic, I think physicians and other clinicians are going to be faced with some pretty tough decisions and are going to be placed under extreme amounts of stress. And, it's clearly not an ideal way to be practicing medicine. And, unfortunately, the likelihood of a mistake is probably much higher than normal. So as I said, there have been a couple of states that have taken the proactive step of saying, during this time, unless there's gross negligence, you're not going to be liable as you would normally be for potential allegations of malpractice.
That's something that, looking forward, I think we're going to see roll out. And you've mentioned some of these changes are going to last. We may well see the continued reimbursement of telehealth, allowing telehealth relaxation around HIPAA issues around telehealth. That's not going to be made permanent. Would you agree with that? That's going to be brought back into after the emergency.
Yeah, no, I think the HIPAA will snap back pretty fast. And as I said, my kind of gut feeling on it is it was great to have an optic thing of saying, yeah, you can be able to get it rolled out immediately because everyone has some of these general services on their phones and probably use them in their personal lives all the time. But kind of as I said, it's also not necessarily a high lift to be able to get a compliant service in place. So yeah, I definitely agree with you that some of the changes will hopefully be permanent, but other ones clearly are definitely just a circumstance of the emergency.
Well, Mr. Fisher, we're almost totally out of time, but before we sign off, I want to make sure folks know how they can contact you. Could you give us your email address or the best way to contact you?
Sure. So email, as you said, is a good one. So that's mfisher, and Fisher is Fisher at myrickoconnell.com. So that's all one word, and it's MIR as in Robert, I, C as in cat, K, OCONNELL.com. I think, as you know, I'm pretty active on social media, so you can always catch me on Twitter. That's at Matt with 2 T's _R as in Robert _Fisher. And then, like you, I've also got a show on the on Healthcare Now Radio. So yeah, so you can listen to my show, Healthcare de Jure. Like yours, it airs a new episode every 2 weeks, and I think there's some good ones coming up. So I hope everyone after listening to your show will hop on over to mine.
Right, and Matt, let me tell folks that they can reach your program page at healthcarenowradio.com, and I recommend everyone do that. Well, to our audience, listening audience today, thanks for joining us on this episode of the Tate Chronicles. I offer a special salute to my guest, Matt Fisher. Matt, thanks for coming aboard today.
Yeah, no, thank you very much again for having me, Jim.
I want to thank Hewlett-Packard for sponsoring today's episode. You could learn more about HP and their Healthcare Edition products that were designed with clinicians in mind to streamline patient care, and optimize clinical workflows. And you can find out more information at hp.com/go/healthcare/US. You can find more information on the Tate Chronicles on the show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.